So this is another topic where I actually thought I did a video on my channel, but realized that I actually didn't. So let's talk about Meconium Aspiration Syndrome, also referred to as MAS. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at Meconium Aspiration Syndrome. If you haven't yet subscribed to the channel, hit the subscribe button, hit the bell notification icon, so you should be receiving notifications of such amazing content every time I post. Grab a piece of paper and let's go. So remember that Meconium aspiration and the passage of meconium actually is fairly much more common in a term baby. The reason being, the term baby has a mature GIT, and it's most likely that if there's any stressing event or anything that's happening during the pregnancy or even at delivery, can easily allow the GIT to be stimulated and that meconium to be passed. Remember that meconium is pretty much going to be passed 24 hours after delivery in a term baby, and sometimes this meconium can be passed before the child is actually born. And there's a risk of aspiration of this meconium. So meconium aspiration can be caused by intrauterine or intrapartum aspiration of meconium stained amniotic fluid in term babies as well as post-term babies. It's not so common in preterm babies because their GIT is not yet fully developed. Remember that meconium, or quote-unquote the first stool, is going to contain material in the fetal gut, and it's going to be consisting of water, mucopolysaccharides, desquamated skin, gastrointestinal mucoso-epithelial cells, mucus, secretions, lanugo, which are hairs, vernix caseosa, which is this oily substance that covers the skin at birth. You also have bowel salts and amniotic fluid. So remember that essentially the meconium is sterile and it's not going to be consisting of any bacteria. And that's the primary differentiating factor between meconium and stool. And it's actually much more common in post-term babies than it is in preterm babies that are in fetal distress. Remember that if this infant that becomes acidotic inside the uterus inhales this thick meconium, then they may develop what is referred to as Meconium Aspiration Syndrome. So remember, these asphyxiated infants, whenever they're being born and they're not getting enough oxygen from the placenta for some reason, then they're in this fetal distress, they may start to gasp. And once they start to gasp, they may actually aspirate the meconium before delivery. It's actually passed before birth in about 8 to 25% of the babies, and the reason why it's rare before the 37 weeks of completed gestation in preterms is because of course, the development of the GIT. And remember that it occurs increasingly with a greater gestational age, affecting about 20 to 25% of deliveries by 42 weeks, as well as those that are small for gestational age. So remember, the event that is going to be triggering the passage of meconium is pretty much this acute or sometimes even chronic hypoxic episode. Sometimes it can be due to infection, such that in this setting, there's going to be gasping that's going to be stimulated into the fetus or the newborn, and then there's a higher chance that they will aspirate this meconium containing amniotic fluid. Now, what are the factors that facilitate this passage of meconium? Acidosis, placenta insufficiency, maternal hypertension, preeclampsia, infections, oligohydramnios, maternal drug use such as tobacco smoking and cocaine use. And remember that aspiration of this meconium into this bronchial tree is going to be either causing this complete obstruction or partial obstruction of the bronchial segments, and this can actually lead to patchy areas of subsegmental atelectasis. It may also lead to compensatory areas of hyperinflation. So features that are very, very similar to COPD. So what exactly happens? Like I said, you have this gut which is matured, and this hypoxia is stimulating the parasympathetic system, and you're going to have a lot of vagal output that's going to stimulate this mature gut. So what's going to happen if there's a lot of vagal output that's stimulating this mature gut? It's going to cause the muscles of the wall to contract, the sphincters will relax. So remember, meconium is often passed as a consequence of distress, as a consequence of hypoxia in a fetus that's going to be term, and it becomes much more frequent as they go towards 42 weeks of gestation. And remember, as they approach term, like I said, and the GIT matures, you get this vagal stimulation which is coming from the head or the spinal cord, compression, and then this may actually lead to peristalsis and relaxation of the sphincter, and then passage of this meconium, like I already explained. So the degree can actually range to just slightly amniotic fluid that's stained with meconium, which we call that as meconium grade 1, or it can sometimes be slightly in between, we call that as grade 2, and sometimes it can be quite thick and dark green, we call that as meconium grade 3, where it's even actually pea-souped. Now remember that this same meconium stained fluid can actually reach the distal airways, it can reach the alveoli as the fetus is in utero, and they can actually become hypoxic, and they will develop this gasping and then these deep respiratory movements, and then this is going to cause the child to have this first inspiratory breaths whilst they're still intrauterine, and this will mean that this meconium stained fluid can easily enter into deeper into the lungs. So remember the effects of meconium in amniotic fluid. Remember that meconium directly alters the properties of amniotic fluid, thereby reducing the antibacterial activity of amniotic fluid, and this increases the chance of perinatal bacterial infections. Even though meconium itself is essentially sterile, but it will decrease the properties of amniotic fluid and allow bacteria to easily set in. Then meconium itself is irritating to the skin, so the children may have a higher incidence of erythema toxicum, and of course there's going to be perinatal aspiration of meconium stained amniotic fluid. So what are the mechanisms to which this meconium stained fluid actually is going to be causing hypoxia? You have 4 main mechanisms. So one, it could be due to the obstruction, the mechanical obstruction, which is either complete or partial. When you have this partial obstruction, you get this air trapping, this hyperdistension of the alveoli, and this is what we call the Bohr valve effect. So the trapped gas can actually rupture into the pleura, resulting in a pneumothorax. It can rupture into the mediastinum, resulting in a pneumomediastinum. It can rupture into the pericardium, causing a pneumopericardium. And then also meconium actually deactivates and inhibits the production of surfactant. And remember, surfactant is actually a constituent that's going to be helping you reduce the work of breathing. So even the constituents of meconium are going to be having these free fatty acids that have a higher minimal surface tension than surfactant, so they're going to strip off the surfactant from the airways, and the airways can easily collapse, and you have this surfactant dysfunction. Then it also is an irritant. It causes a chemical type of pneumonitis, where you have these enzymes, the bile salts, the free fatty acids in the meconium that can actually irritate the airway and the parenchyma. And of course, this begins within a few hours of aspiration. It may also cause persistent pulmonary hypertension of the newborn, where infants that have this primary or secondary persistent pulmonary hypertension of the newborn is going to be a result of this chronic in utero stress, this thickening of the pulmonary vessels, such that this causes this hypoxemia, and this can actually result in pulmonary infections despite this meconium that they've aspirated being sterile. Now, what are some of the clinical features that we're going to be expecting? Remember, they may range from mild to moderate respiratory distress, generally in the few hours of life. So this is one of the causes of respiratory distress in a term child. And then of course, they are going to often deteriorate in the subsequent 24 to 48 hours. So they may have features of tachypnea and expiratory grunting, nasal flaring, intercostal recessions, a barrel chest because of the air trapping. Remember, the changes are quite similar to what we see in emphysema. Then you may also see cyanosis. You may hear some rhonchi, or you may hear some rails or crackles or crepitations. So eventually some are going to develop this severe respiratory failure with severe hypoxemia and cyanosis. So if you don't actually ventilate these children adequately, they will die. Then remember that meconium is a lung irritant that's going to be causing this chemical pneumonitis. And when you examine this child, you're going to be seeing this yellow greenish stain in the fingernails. You may even see it on the umbilical cord, even on the skin. That may hint you towards meconium aspiration syndrome. And remember that meconium staining on intubation in the larynx and the trachea can sometimes also be seen. How do we make a diagnosis? Remember, it's going to be suggested by a history of meconium that's noted before delivery and the presence of respiratory distress. So our diagnosis is going to be including things like the presence of meconium stained amniotic fluid. You may also have neonatal respiratory distress and even certain characteristic radiological findings. When we get an X-ray, we may see features that are very similar to emphysema. So you may get this overinflation of the lungs, which is going to be accompanied by some patchy collapses and sometimes even consolidation. So you have this increase in the lung volume, which we call hyperinflation. You may have this diffuse asymmetric patchy infiltrates. You may sometimes have areas of consolidation. This is worse on the right. And this makes sense because if you look at the division of the bronchi, the right side is almost in line with the trachea. So if anyone aspirates anything, it more or less will end up on the right side. Then you have sometimes a pneumothorax because of the Bohr valve effect of the meconium, depending on the severity of the clinical picture, or a pneumomediastinum, which may occur in 25% of the patients. Remember, blood cultures may help distinguish bacterial pneumonia from the chemical pneumonitis that we see in meconium aspiration syndrome. Now, here is an X-ray. There's going to be this hyperinflation of the lungs and heterogeneous opacities in the right lung, as you can actually see here depicted on the picture. Now, what's our management going to be? Generally, prevention is the paramount, most important thing. So, initial assessment at delivery, complicated by meconium-stained amniotic fluid. You want to determine whether the infant is vigorous, as demonstrated by the heart rate greater than 100, or spontaneous respiration and our good tone. These are features of the APGAR score. So if there is vigorous routine care, this should be provided regardless of consistency of the meconium. If there's respiratory distress that's going to be developing, or a depressed infant, tracheal intubation under direct laryngoscopy and intratracheal suctioning can actually be done. So remember that this routine suctioning that we do, for example, intubating to suction below the vocal cords of a neonate that's delivered with meconium-stained fluid, has actually not been shown to improve the outcome. However, if you get this neonates that's breathing appears to be obstructed, you can actually suction, and you can do this with an endotracheal tube attached to a meconium aspirator. Then the best approach to the meconium-stained fluid is actually combined obstetric as well as pediatric approach. So there's supposed to be minimal handling of the child to prevent agitation, which may worsen the condition and predispose to pulmonary vasoconstriction. It can also predispose to persistent pulmonary hypertension of the newborn. Then, of course, oropharyngeal and nasopharyngeal suctioning on the perineum, though it's not really effective in preventing meconium aspiration, and you sometimes have a direct suctioning of the trachea via the endotracheal intubation. If the baby is actually born in a good condition and is crying, there's no suctioning that's actually needed. However, if the baby is born in a poor condition or they're not making any respiratory efforts, the oropharynx and even the vocal cords should be suctioned under direct vision before actually starting this intermittent positive pressure ventilation. Now, remember that the whole thing here is that this child is hypoxic and this meconium is increasing the work of breathing. There's not enough effective gaseous exchange, so you want to manage the hypoxia. So generally the oxygen is going to be required, and this is going to prevent persistent pulmonary hypertension. And if the meconium aspiration syndrome is severe, then you can actually go for a CPAP, you can actually have mechanical ventilation, or you can have extracorporeal membrane oxygenation, which is the ECMO. Remember that when you have the assisted ventilation or CPAP, I did the video on CPAP, so I will leave it tagged here that you can actually click on it and actually swing by and watch that video. So you may actually consider it when the saturations are less than 90%, if the fraction of inspired oxygen is greater than 0.41. However, the CPAP sometimes may aggravate the air trapping and should be instituted with caution if the hyperventilation, or rather hyperinflation, is quite apparent clinically or radiologically. Then you do also mechanically ventilate these children, and this is required if they have this excessive carbon dioxide retention and a partial pressure of carbon dioxide greater than 60, or if they have this persistent hypoxemia of an oxygen partial pressure less than 50. Remember that in infants requiring higher inspiratory pressures, such as 30 to 35 centimeters of water, or a peak expiratory pressure of 3 to 6 centimeters of water, should actually be selected based on response. And adequate expiratory time should actually be set into the machine so that you prevent air from being trapping behind the partially obstructed airway. Remember, some useful starting points are going to be an inspiratory time that we're setting at about 0.4 to 0.5 seconds and at a rate of about 20 to 25 breaths per minute, and then you adjust it according to the response. Sometimes we can offer the high frequency oscillatory ventilation if they're not really coping with the conventional ventilation, and in those that actually develop air leak syndromes, the pneumothorax, the pneumomediastinum, and so on and so forth. Then you may actually give them inhaled nitric oxide up to 20 parts per million, and high frequency ventilation, other therapies that are actually used if there is this refractory hypoxemia that develops, and they actually reduce the risk of or the need for ECMO, which is the extracorporeal membrane oxygenation. If there is any hypoglycemia, you correct that. We restrict the fluids to avoid any cerebral or pulmonary edema. We should monitor our oxygen saturation very closely, our renal function, electrolytes, particularly calcium, monitor the pH because they're likely to go into a metabolic acidosis. And of course, the blood pressure, they may also require inotropes, they may become hypotensive. You may also do your blood gases and your pH, and as well as your hemoglobin. So you maintain it about 15 about 15 milligrams per deciliter, and this improves oxygenation. It's generally an acceptable practice to start antibiotics before you actually get the couches, but it's very difficult to actually distinguish between Meconium Aspiration syndrome and bacterial pneumonia. So we generally just start the children on antibiotics. We use broad spectrum antibiotics, so a penicillin or ampicillin combined with an aminoglycoside, in our case a gentamicin, but this should actually be guided by your blood cultures. Remember that antibiotics are not going to significantly reduce mortality, they're not going to significantly reduce the incidence of sepsis, they're not going to reduce the length of hospital stay, or are they going to reduce the need for respiratory support. Surfactant in some cases can be given because this endogenous surfactant can be inhibited by the meconium that this child has aspirated, but this, however, is not really done routinely, and it may only benefit infants that are actually clinically deteriorating and require escalating support on the respiratory system. Then it can actually decrease the need of them actually going onto the extracorporeal membrane oxygenation, but it doesn't really decrease the mortality rates. Sedatives may be warranted if they do require mechanical ventilation. The prognosis is generally good, although it varies with the underlying physiological stresses, as well as the overall mortality is increased. In infants with actually Meconium Aspiration syndrome, it may actually be greater risk of them developing asthma in the long run. Complications include air leak syndromes, which account for 15 to 33% of the cases, and it's actually common with mechanical ventilation, especially in the setting of airway trapping. So they may develop a pneumothorax, they may develop a pneumomediastinum. Newborns may actually develop persistent pulmonary hypertension of the newborn, and then they may have a pulmonary sequelae where they have this chemical pneumonitis, which is complicated by bronchopneumonia. Long-term reactive airway disease may actually be seen in some of these patients. I really hope you enjoyed this video on Meconium Aspiration. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazivu. Until next time, bye-bye.